All right, we may have a couple more people come in, but we need to get started because we have a lot to cover today. Depression is a big topic. And so we're going to talk about postpartum depression, seasonal affective disorder, briefly before we get into major depressive disorder, which is where we'll spend most of our time. And at the end, I'll talk a little bit about bipolar disorder, which is another type of depressive disorder. So there's really 4 different kind of subcategories under depression. So, what is postpartum depression? It is a form of depression that happens after childbirth. 1 in 7 women experience it. There's also, we'll talk about depression in terms of severity. So sometimes people will, be down in the dumps, sort of, not feeling great, but it's not really meet the diagnostic criterion for depression. And so sometimes we call that sort of having the blues, right? And so baby blues is very common. As you can imagine, after having a baby, it's a very stressful time, and your sleep is also disrupted. So, men can also experience postpartum depression as well. It's not just something that affects mothers, although it affects women much more than men. And part of this, obviously not for the men, but for the women, there's a lot of hormonal changes that are happening after having sort of elevated levels of hormones that are sustaining the pregnancy during the 9 months, and then to have all of those hormones rapidly shift with birth. And there's a lot of psychological demands and issues with sleep as well, right? So sort of the key on this is if it's happening for longer than 2 weeks, and if it's getting worse, or if mothers are having a hard time caring for themselves or caring for their baby, or have any thoughts of harm for the baby or self-harm, those are sort of the delineating points, the symptoms where someone should really seek help for this, right? So sort of looking at the difference in these, I'm not going to really play this video because it's just sort of what I'm saying right now. But again, baby blues are lesser severe sort of form of this. And then you can see with postpartum depression, there's major mood swings, reduced interest or pleasure, crying, weight loss, changes in sleep, inability to think clearly, those sorts of things. All right. So, what do we think causes this? Well, as I mentioned, there are psychological demands that are happening. There's stress of having to take care of a brand new baby. I remember when my wife and I left the hospital when we had our first child, and we got back home and like sat on the couch and I can't believe they let us leave the hospital with this human being that we have to keep alive now. It's really sort of it hits home, right? And infants, so this is the sleep-wake record of a newborn. And for the first 8 weeks, they really don't have any circadian rhythms. They don't have a sleep-wake cycle, and so that's very disruptive to the parent's sleep-wake cycle. And then for the next 8 weeks, you start to see what we call a free-running rhythm emerge, right? Where they are having periods of time that they are sleeping for longer periods of time, but it's still not regulated in terms of a light-dark cycle until we get to about 16 weeks out. So there's quite a prolonged period of disrupted sleep for parents. I thought this sign was really great. Sometimes you see this on doors where people are telling delivery people don't bang on the door, don't wake up the baby, that sort of thing, right? Okay. There's also can be a fear of failure, and women also commonly report sort of a sense of loss with the pregnancy. So most women really enjoy being pregnant. carrying the baby to term, and then there's sort of a loss of that period. In addition, there's these big neurochemical changes that are happening. As I mentioned, hormonal shifts of estrogen and progesterone that were high during pregnancy to sustain the pregnancy now drop. You also have changes in prolactin for breastfeeding and oxytocin. So lots of different hormonal shifts that are happening. So changes in oxytocin and prolactin as well. Increased stress hormones can have all of the negative effects we talked about. So we've talked about both good sleep hygiene or being important for mental health, but also poor sleep hygiene being critical, being a contributor to issues. And then we also have all of the things we talked about with stress, right, with elevated cortisol levels. A recent study, this came out last year, did brain imaging for a single female that during her pregnancy. So they started prior to conception and then measured her white and gray matter throughout pregnancy and then in the postpartum time as well. And what they found, and again, this is only a single person that they did this study on because it was pretty expensive to do these scans and we're tracking it over a long period of time, but I think that this will get replicated and we'll see more studies looking at this. But there are some pretty dramatic changes in the brain during pregnancy. And so the connectivity in the brain increases. And so here we see in the second trimester this high sort of increase in connectivity. So again, they're measuring white matter connectivity here. And then at birth, that connectivity goes away. It goes sort of back to a pre-pregnant brain. And so these changes in how the brain is able to communicate could also make the brain susceptible to depression. So we're going to talk about major depressive disorder as a circuit level disorder. So it's a weakening of circuits that support our mood. And so here you can see that with these changes in white matter, you can also have weakening of these circuits that could result in postpartum depression. Normally, postpartum depression can sort of correct itself, right? So the hormone levels stabilize, these changes in the brain stabilize, and often people are able to sort of come out of it on their own. So treatments, there's a lot of, there can be barriers to treatment, stigma. A lot of people don't want to admit that they're struggling as a new parent. You feel like, oh, I should have this, I should be able to do this, right? So feelings of inaptitude or that you're not doing everything exactly right, especially for a first child when you're your first time doing this as a parent. And so part of reducing that stigma can be to have an awareness of this, talk about it, say, hey, this is a normal thing, that this is a change that's happening in your brain. And sometimes it is severe enough that people do need therapy, do need treatments. And so social support can be a really helpful part of this. Giving parents, especially new parents, tools, so parenting workshops, and then sometimes people do need to go to therapy and talk about some underlying issues maybe that may have risen up in this period. There are 2 SSRIs and 2 tricyclic drugs that are approved to treat postpartum depression that are safe if a woman is breastfeeding. These particular 4 medications are safe for that. So Zoloft, Paxil are the SSRIs, and then Tropinil and Pamela are the 2 tricyclic drugs. All right, a minute on seasonal affective disorder. This is depression linked to seasonal changes, typically winter. Again, there's sort of a milder version of this that we call winter blues, right? It is 4 times more prevalent in women than men, and we also see that major depressive disorder is more prevalent in women than in men. And the research article that you're going to read talks about some of the reasons why that could be the case. That there are some fundamental differences in serotonin transporters and serotonin receptors, we think, between men and women that make women more susceptible to depression. Where you live also matters, right? So the further you are towards the poles, right, the further away from the equator, the more drastic the light-dark changes are during wintertime. And so seasonal affective disorder only has about a 1% prevalence rate in Florida. It has a 9% prevalence rate in Alaska. And in fact, we'll see one of the major treatments for this are using light therapy, phototherapy. And I haven't been to Alaska, but I've heard that, like, you know, you go to Walmart in Alaska and they have displays of these phototherapy boxes, light boxes that you wouldn't see elsewhere. Overall, about 500,000 people are affected in the U.S., with a greater number, 10 to 20%, reporting some kind of winter blues, so that they don't feel as happy in wintertime. Right? We see an increase of prevalence in places like Canada and the UK, again, that are higher latitudes that have shorter daylight periods during wintertime. So what do we think is happening? Well, we think that it's related to circadian rhythms. We know that serotonin is a signal for sleep. Again, sleep playing a major role. So when we have impairments in our sleep quality, it can affect our mood as well. And so some of the other things that have been looked at is that 5% of the people that report seasonal affective disorder appear to have changes in their serotonin transporter proteins during the winter, so that serotonin becomes less effective for them in the wintertime. There's also sort of an overproduction of melatonin and a decrease in vitamin D. And we get vitamin D from sunlight, so not having as much sunlight can result in lower levels of that. So what we think is happening with the circadian rhythms is because our circadian rhythms tend to be longer than 24 hours, they have to be reset every day. And the way our body resets our circadian rhythms is with sunlight. So sunlight comes in and sort of resets that clock in our suprachiasmatic nucleus that regulates our circadian rhythms. And so when we don't have access to that sunlight first thing in the morning, our clocks can't get reset as effectively, and that can, in some people, result in depression. So, here we go. So this is what this phototherapy looks like. You can buy it on Amazon for $25. The important thing is that it needs to have at least 10,000 lux, so it needs to be bright like sunlight is, right? So just turning on your fluorescent light or incandescent LED light in your room isn't going to provide this. And it has to have the same photo wavelengths that sunlight has. Typically, somebody could sit for 30 minutes in front of the light therapy in the morning, and that will reset your circadian rhythms. And this tends to be a pretty effective treatment for seasonal affective disorder. Other treatments can involve taking vitamin D supplements to sort of keep that vitamin D deficiency from happening. And if it's severe enough, sometimes drugs are necessary. So SSRIs are the common selective serotonin reuptake inhibitors to increase the amount of serotonin. Therapy doesn't really seem to be to play much of a role in this. This is really a physiologically driven depression that responds well to the light, resetting circadian rhythms, but if not, drugs are helpful for that. But therapy doesn't usually work because it's not an internal issue that's happening, right? It's this physiological difference in time, in light cycles. Okay, that brings us to major depressive disorder. So here's the DSM-5 criteria. There are 9 different sort of categories of symptoms here. Some of them are cognitively based, right? So you need to have a depressed mood nearly all the time for, what is it, for a month, I think? Or no, for a 2-week period. Yeah. Diminished interest in activities that should make you happy, right? So not receiving that internal reward signal that we talked about when we talked about addiction. And then often there are physiological changes that are associated, again, we think, with abnormalities in the serotonin system. So serotonin, in addition to be involved in sleep, so we have sleep problems, insomnia or hypersomnia, but we also, serotonin is involved with feeding regulation, so often people have either weight loss or sometimes weight gain, but problems with appetite associated with major depressive disorder. All right, so, it's sort of, I think, important to make the point that we're not meant to be like happy and cheerful all the time, right? And we all go through points in our life where situations are difficult and that impacts our mood, but there's a difference between sort of having the blues or being down in the dumps and clinical depression, which is where you have this sort of profound sadness that that nothing can sort of generate pleasure for you. And as I mentioned, there are physical symptoms that are also associated with it. So fatigue, problems with sleeping, and issues with weight and appetite. If we look at genetics, there are some genetic influences on this. If there's about a 3% diagnostic rate of major depression in the general population. However, if you have a first relative that has been diagnosed with depression, that jumps up 3 times to 9% for other first relatives likely having depression as well. So there are some genetic influences on this. If we look at twin studies, again, we can see that fraternal twins, about the same, 11%, about the same as a first degree relative. But then when we go to identical twins, if one identical twin has depression, there's a 40% chance the other twin will also develop depression. So again, this is showing that there's a genetic influence on this. It disproportionately affects women, as I mentioned. And the research paper that I mentioned that you'll read, that we'll talk about on Wednesday, looks at some of those sex differences. All right, so our mood and emotion are controlled by this sort of complex circuit that was originally identified by Pepez as this circuit of emotion, and it has components such as our friend the amygdala that we've talked about, which is involved with emotional value, right? So in this case, something should have positive emotional value, and if they're not able to elicit that, that's a key symptom of depression. The cingulate gyrus involved in this as well. And then we have other areas like the hypothalamus, and so these are sort of color-coded for the different symptoms, right? So amygdala cingulate is more emotion and mood. The basal ganglia, again, regulates this circuit. So we have 3 different circuits running through the basal ganglia: our motor system, our cognitive system that we talk about with obsessive compulsive disorder, and now our emotion system that is regulated by that. And so that lack of motivation, we think, can be linked to the basal ganglia, the hypothalamus, the issues with hunger and sleep. That's where that's happening, right? And then, in general, your frontal lobes is where we're having maybe impaired executive function, decision-making, judgments. Here, you can see an image, a PET scan of somebody with major depressive disorder, and what we see is sort of a hyperactivity of both the frontal lobe and the amygdala, which in general, they're like a seesaw, right? So the frontal lobe kind of controls the amount of activity in the amygdala. And we can think about the amygdala sort of as like the gas, like stimulating our emotional system, and our frontal lobes sort of regulating how much our emotion system is stimulated. And here, it's like you're trying to put you're stepping on the brakes and the gas at the same time in a car, right? And that makes the circuit not work well, right? That makes the circuit not work well. We also see some hypoactivity in the cingulate gyrus here and in the basal ganglia, right? So really thinking about major depressive disorder as a circuit level disease where this circuit is not functioning well. Okay, the amygdala, we've talked a good bit about this, right? It's this processing station for emotional value of things, broad connections in the frontal lobe, connections, as we mentioned when we talked about PTSD to the hippocampus, right? Also connections with our arousal states in the hypothalamus as well as the basal ganglia. So highly sort of connected, again, one part of this circuit that gets dysregulated in major depressive disorder. And when we try to look at where emotion is represented in the brain, it's really diffuse. It is really a diffuse circuit of representation, so there isn't an area for happiness. So these are lateral views of the brain during these emotional states. These are medial views, and you see that all the different emotions are represented in similar areas in a diffuse way throughout the brain. In particular, though, particularly this area in here, in the cingulate gyrus, the anterior part of the cingulate gyrus, we think is another place that gets dysregulated in this circuit, linked to our cognitive and our emotional responses. Okay. When people are in remission from depression, right, we see that these brain areas are very different, right? So the activity goes down in the frontal lobe and goes down in the amygdala. So clearly, a depressive state is related to this circuit not controlling, not functioning well. And when the circuit does start to function well, the depressive symptoms go away. All right. Another important part, in addition to the cingulate cortex, is the orbital frontal cortex and the dorsolateral prefrontal cortex. So the orbital frontal cortex in this area down here, right, is doing a lot of our emotional regulation. So we talked about how that area in CTE can get damaged and people lack the ability to control their emotions. The dorsolateral prefrontal cortex is more of the cognitive aspect of depression. So when people can't concentrate, sort of have cloudy thinking, not able to make good decisions, judgment, this is this area, this dorsolateral prefrontal area. motivation and planning is also part of that. And this is the area that loops through the basal ganglia. That loops through the basal ganglia. Yeah. And then finally, the basal ganglia that we've talked about. If we look in depression, we can see reduced size of the caudate putamen, which is where the input comes into the basal ganglia. And we see, again, hypoactivity, decreased activity in the basal ganglia in depression. Mm-hmm.
So if there's a smaller caudate in putamen, why would there be, which is where like the input comes in, why would there be increased activity? Is it because
there's decreased activity
in
the basal ganglia.
Okay.
Increased activity in the frontal lobe and the amygdala, decreased activity in the basal ganglia. Okay. So we have these brain areas that are connected, this circuit that is supposed to sort of regulate our emotion and has become dysregulated in depression. And obviously there's some neurotransmitters that are involved with that as well. So almost everything that we know about the neurochemical aspect of depression has come from research where we tried a drug and that drug was able to reduce the symptoms of depression. And then people were like, okay, this drug works to reduce the symptoms of depression. What is the drug doing, right? And it tends to be acting on the catecholamine systems. So that's norepinephrine, dopamine, and serotonin. And so the very first drugs that were introduced were MAOIs and tricyclics. MAOIs are monoamine oxidase inhibitors. That is the enzyme that breaks down serotonin and dopamine in the brain. And tricyclics were drugs that acted to boost all of the catecholamines, so norepinephrine, dopamine, and serotonin in the brain. So those were sort of developed in the 50s and 60s. In the 70s and 80s, a new class of drugs was discovered and developed called SSRIs, selective serotonin reuptake inhibitors. And so there, because tricyclics acted on all of the catecholamines, norepinephrine, dopamine, and serotonin, that was sort of the predominant theory. So a lot of our theory of what's causing depression has come from the fact that these drugs that act on certain neurotransmitters can reduce the symptoms. So we don't really know that there's an issue with these neurotransmitters, but manipulating them can improve the systems. So when the SSRIs became popular, that led to this serotonin hypothesis. And for a long time, people incorrectly sort of referred to depression as being a serotonin imbalance in the brain, that you didn't have enough serotonin. If you simply could elevate serotonin in the brain through these SSRIs, then you can effectively treat depression. And it's much more complex than that, because you don't see the improvement in the symptoms for weeks after being on these drugs. So if it was simply a chemical imbalance like dopamine is in Parkinson's, that's like one of the best examples of a chemical imbalance. We give somebody L-DOPA, and 30 minutes later their symptoms are gone, right? Missing dopamine, give them L-DOPA, symptoms immediately go away. Here, if you're saying, okay, low serotonin, we give you SSRIs, serotonin gets high, but your symptoms don't immediately go away. It takes keeping those levels elevated for weeks for the symptoms to slowly improve. So what we think these drugs are doing are, by elevating serotonin, we're strengthening that dysregulated circuit, and over time, as that circuit gets stronger, that's when the symptoms disappear. Sort of the latest emerging medications are SNRIs, so selective norepinephrine reuptake inhibitors, that sort of act dually on both serotonin and norepinephrine. Again, there's not, we need to sort of get away from this myth of thinking that antidepressant drugs like correct depression or fix depression because it's an imbalance. It's not an imbalance. Okay, so as I mentioned, the catecholamines in general tend to be what we call neuromodulatory. They're not, dopamine is doing discrete signaling in the nucleus accumbens for reward that we talked about last week. But other places in the brain, it tends to be more regulatory. You think about sort of the role of dopamine in the basal ganglia, right? It sort of regulates that flow of information through the basal ganglia. And serotonin is much more complex and much more diffusely spread throughout the brain, used in lots of systems, and can play a neurotrophic role as well. Right? So what is the evidence for I don't want to say dysregulation, differences in these neurotransmitters in people with depression? We can measure lower levels of norepinephrine in depressed patients compared to non-depressed. We can measure increased levels of serotonin or norepinephrine when people are on these medications, right? So the medications do increase the availability of these neurotransmitters. And again, over time, they can help reduce the symptoms. There's also a strong connection, again, with sleep and major depressive disorders. So 50% of people with depression report insomnia or multiple awakenings, so they're not getting that restorative slow wave sleep, and their REM sleep is sort of scattered throughout the night. And so again, think about what do we think the role of those types of sleep is. Slow wave sleep is supposed to happen, the majority of it, early in the night to sort of sort through memories and clean up the brain. And then REM sleep is supposed to happen towards the end of the night to sort of solidify those memories and maybe scrub emotion off of the memories. There's been some research that suggests that sleep problems may predict future depression, right? They may actually precede people becoming depressed. And in people that have had a major depressive episode and are now in remission, changes in their sleep or disruptions to their sleep quality can also trigger a relapse of depression when they're in remission. So sleep deprivation often triggers episodes. One of the another study looked at major depressive patients that were in treatment, and those that were in treatment that had better sleep quality and better sleep hygiene, the treatment worked better for them. They were able to get have quicker reductions in their depressive symptoms. So sleep not only important, or it could play a role, disruptive sleep could play a role in the emergence or maintenance of depression, but having good sleep can actually help with the therapeutic benefits of getting better. There are some people that when they have depression, if you deprive them of sleep for one night, the depressive symptoms go away the next day. And obviously, that's not an effective treatment, right? And as soon as they get a regular night of sleep, the symptoms come back. What this tells us, though, is that there is a role of serotonin here. So serotonin's role in sleep is it's very high at the start of sleep. So serotonin kind of builds with sleep pressure, and the longer we go without sleep, the more serotonin our brain's making, sort of trying to tell us, hey, you need to go to sleep. So if you've ever been sleep deprived, you know the next day there's this strong sleep pressure for you to go to sleep. And so what we think is happening is that your brain is naturally overproducing large levels of serotonin after the sleep depression. And that boost in serotonin is what is allowing the depressive symptoms to go away the next day. But as soon as we alleviate the sleep pressure with a night of sleep, those serotonin levels drop back down and the benefit goes away. Yes,
Is that
ma'am?
like usually when you're pretty sleepy, you start to feel like maybe a little more like goofy or something, just because your serotonin's boosted?
It could be. It could be. I don't know that anyone's sort of definitively looked at that.
Yeah.
Right. Okay, so why do we see an immediate effect of sleep deprivation on decreasing symptoms, but when we take drugs to increase serotonin, we don't see that immediate effect? Why do you think that would be?
Because the drugs acts in like multiple steps, like multiple messages.
Yeah, so the drugs are sort of artificially trying to increase serotonin by blocking its reuptake, right? So your brain, and so what would be your brain's natural response to that?
Make, if they're blocking more reuptake.
To make more things that break it down.
Yeah, so to compensate, right? So to either release less serotonin because it's staying around longer in the synapse, or increase your effectiveness to get rid of it, right? And so part of the theory for why, and then here with the sleep deprivation, your brain is naturally overproducing serotonin, right? So a big difference in how the serotonin changes are happening in our brain for sleep deprivation versus taking the drugs. Not everybody responds to this. So there are some, like here we see in blue, the responders after a night of depression, their symptoms have gone down, their mood is elevated. But there are people whose sleep deprivation doesn't affect their depression. And so this could indicate that in some depressed people, there's more of a role of maybe norepinephrine and not serotonin. So there could be multiple things involved. And again, if we think of it as a weakened circuit, it may be that in some people, norepinephrine, the circuit's weakened in a way that norepinephrine is the key to strengthening that circuit, right? But in other people, serotonin is the key to strengthening that circuit. Okay. So, pathways. You don't need to know all these molecular pathways, but what you do need to know is that there are some common pathways that can have genetic influences, right? So that's where the genes come into that. Right? That stress can play a role in weakening this circuit. Right? Cardiovascular disruption, right? So depression is often a comorbid symptom of stroke. And so if we compromise our ability to get oxygenated glucose in the brain, that can weaken circuits. Repeated episodic illnesses, so basically anything that could cause like inflammation or weakening, cause that circuit not to be functioning at 100%, could result in depressive symptoms. And you know, how antidepressants, like the elevation of serotonin, we don't exactly know how that's strengthening these circuits, but we think that it is acting in this neurotrophic way because, again, it takes time, it takes weeks for those symptoms to get better. All right, so these are the two major sort of drug classes, as I mentioned, blocking the breakdown, enzymatic breakdown, so MAOI drugs. And so here we see effectiveness of drugs versus placebo. So this is change from baseline, right? And again, I want to point out that this is 30 days out that we're seeing the highest drug effects, right? So it takes time of being on these drugs, usually about a month, 4 weeks, to sort of get the maximum benefit of those. All right, so as I mentioned, when we go in and we manipulate and block reuptake and cause or block the breakdown of serotonin, we're elevating the presence of serotonin in the synapse, and our brain wants to compensate for that. We have feedback autoreceptors here, measuring how much serotonin is being released. And so one of the thoughts of why this might take some time is that our brain has to sort of learn to quit compensating for the drug effects in order for the drug effects to start having the ability to strengthen those circuits, right? So you begin the treatment, drugs are increasing right away, they're acting to increase serotonin, but there's then this sort of pullback by the brain to say, hey, I'm not going to release as much serotonin because I'm sensing that there's high levels in the synapse already. And over a period of weeks, maybe a month, right, the system kind of resets and sort of learns, okay, this is the new normal. I don't have to keep pulling back from releasing serotonin. I can go back to sort of my normal, and then those serotonin levels actually start to rise due to the medication, and we start to see the effects on the circuits. Okay. So that may take a period of weeks for our brain to learn to quit compensating, essentially. All right. Other explanations for why we see this delay. It could be that serotonin, likely, like here we have the depressed brain, and you can see that some of the neurons are not functioning well in that circuit. And during drug treatment, we're providing this sort of neurotrophic support to stimulate that system. And the idea is that that system gets strong enough that it becomes recovered, is no longer weakened like this, and that we can get off of the, we can wean off of the drugs. Again, stress plays a role in this. So here we see circulating levels of cortisol, and we have normal controls. We have psychiatric controls in this study that did not have depression, that had other psychiatric conditions, and then primary depressives. And what we see is that in a lot of primary depressives, there's elevated cortisol release. But it's not high in all of them, right? So here's a group of people that are depressed that don't have elevated cortisol. So it's one sort of factor that can contribute to depression, right? So stress doesn't necessarily cause depression, but in a system that would be susceptible, so those circuits are already kind of weak to begin with, stress could trigger an episode for sure. Stress during development, so early on postnatal stress, we think, can affect how these circuits are developing in the brain and could make brains more susceptible to future depression. And so what we know happens here is in this circuit, right, between the cingulate cortex, the dorsolateral prefrontal cortex, the amygdala, the hippocampus, and the hypothalamus, right, that when we have high levels of circulating cortisol, it can cause neurodegeneration, as we saw with PTSD, right, and can weaken circuits in the brain, right? And so again, this leads to hyperactivity in the amygdala, decreased regulation of the amygdala by the frontal lobes. And again, all of this are ways in which stress can abnormally affect and weaken the ability of these circuits to function properly. Okay. So first line treatments. I thought I was good. Maybe I didn't talk about that. So getting into treatments, the sort of first line treatment is often medication, antidepressants, so typically SSRIs, but then also psychotherapy. So often there are underlying conditions that are contributing to the depression, right? Depression has feelings of self-worth, and so working on self-esteem, working on how we interpret other people, other people's interpretations of us are things that people can work through in therapy that can help. When drugs and therapy are not effective, ECT, which is applying electricity to the frontal lobes, or transcranial magnetic stimulation, which is a newer form of manipulating brain activity, these things can be effective. And we think, so here, we're going in and artificially, either with electricity or with these magnetic waves, strengthening this circuit in the brain, right? And the depressive symptoms go away. But over time, that effect wears off. So it only lasts for about 6 months, and then people have to have another treatment. Their depressive symptoms tend to reemerge. So again, we have 3 different types of therapy, all of which look like they're acting to strengthen a weakened circuit, and that's how they reduce the depressive symptoms. Okay, things that we know that are happening with ECT and TMS is that it can change our release of serotonin and change our blood flow, the activity levels in parts of the brain. It looks like ECT strengthens circuits in the brain. In animal research, we see increases in serotonin, increases in neurotrophins in response to both of those. Okay. Cognitive behavioral therapy, as we've talked about in here, a 12-week session of that. It can be equally effective as drug therapy. In fact, it can even be more effective. So cognitive behavioral therapy has a relapse rate of about 36% in major depressive disorder. Drugs have a relapse rate of 72%. So when people are solely relying on the drugs to treat antidepressants, it's sort of like what we talked about with obsessive compulsive disorder. You take the drugs away, and immediately the symptoms reemerge, and they have a relapse, right? So this black line is showing survival means, like 100% means we haven't had a relapse, right? So the lower that number gets, right? This means that only about 10% of people after 24 months, after 2 years, that are on placebo are still being effectively treated, compared to about 50% with cognitive behavioral therapy.
What's the difference in the prior CT and the placebo? Or, excuse me, the compliant?
Yeah, so they have a drug, just drug, and then they have a subcategory of that where they measured to see if people were being compliant taking their drug, right? And so when they checked and made sure they were being compliant, it was slightly higher because people tend to forget to take their drug or don't take it regularly. So this is, again, the drugs we think are acting to strengthen these circuits, and if you don't take them regularly, then they're not building up and having that effect, right? Probably the highest success rate is starting someone on drug therapy and psychotherapy, because the drug therapy can help lift them out of the depression and get their brain to a place, kind of like what we talked about with OCD, where they can actually engage and do the cognitive therapy and do the homework and participate in that. And then eventually we want to sort of like crutches, wean them off of the drug and let the cognitive changes in their brain take over and maintain that circuit and keep that circuit strong. All right, so again, this slide is basically just showing you that all 3 of these therapies, psychotherapy, drug therapy, and directly stimulating the brain, likely are strengthening circuits. They're all doing it in different ways, but that's how they're eliminating the depressive symptoms. BDNF is a neurotrophin. In the brain, when we don't have enough BDNF, then circuits get weak. Depressive treatments tend to increase BDNF. Stress tends to decrease BDNF. Exercise increases BDNF, so exercise can be an effective sort of side therapy for treating depression. And again, here's sort of in stress, this dysregulated system, and when we stimulate with transcranial magnetic stimulation, particularly the dorsolateral prefrontal cortex, we're strengthening that regulatory control over the amygdala, and that's how we think some of those treatments work. So again, drug treatments work on the order of weeks, right? Stimulating the brain can strengthen that circuit very quickly, but then it goes away after about 6 months. It sort of wears off. Okay, so weakened connections here that get strengthened with TMS. All right, I'll start with bipolar. I just have like 3 slides on bipolar. I'll go ahead and post them. But we'll talk about that at the start of class on Wednesday, and then we have your research paper. All right, see you then.